They must have been so neat. Usually get like those little big ones.
That's right.
Very well made. It's about 10 after. I think we're going to go ahead and get started. I think we're going to have several other folks that will be joining us. And can everyone that's online, can you hear me okay?
Yes.
Okay, great. So we have some people. Excellent, good. So again, I appreciate everyone's time. It's exciting. It's a great turnout today. Again, this is James Pat. I'm the President and CEO of InXite. I've been working with Randy Leidy from Ohio University to help us set up the Center of Excellence. And it's really phenomenal to see everyone here and also to see how far we've come in such a short period of time. So today's a really full day. I'm really excited to kind of step through the agenda with everyone. The agenda is up here. I'm going to start with kind of just giving a recap. And it looks like there's a lot of new faces here. So just quickly, show of hands, how many of you, is this the first meeting that you've been at? Wow, fantastic. Great. So I'm going to give a quick recap of why we're here and what this is all about, and talk about the different working groups that we've established over the last several months. And it's very exciting, and to actually give the opportunity for several of the chair teams to come up and give an update about the work that they've been doing. We have social services group, medication management, TBI, quality measurement, there's 9 working groups now that we've set up and established. So all in all, we have 9 working groups. I think we have well over 100 different participants across the working groups. So it's exciting to be there. And I'm going to talk about the chronic care management work group that really tries to tie in all the efforts from the individual teams and actually give a demonstration of the work that we've done since we started this journey. And I'm really excited. I'm hoping I downloaded an app to actually be able to display what I have on my phone on here. If we can get it to work on time, it'll be great. If not, you're going to have to use some of your imagination. But anyways, maybe we can start with introductions. And if you can just introduce yourself and a little bit about yourself, would be great. And I'll start over here with you, Steve.
Steve Swart, CEO, founder of Wise Solutions, former health center CEO, CFO, experienced in value-based contracts from the clinical standpoint. We were the top-rated practice for 4 years in a row in West Virginia. So I've got experience of actually trying to be paid on value-based contracts, and there were no two alike in terms of all 4 of those contracts. My experience was that I think everyone's trying to find out where we're going, and no one's quite sure where we're going to yet. So.
I'm Sudhir Gadam, President of Numeric Technologies. We specialize in data science, data analytics, and application development.
Good afternoon, I'm Larry Schieber. I own Schieber Pharmacy in Circleville.
I'm Ernie Boyd. I'm Executive Director of the Ohio Pharmacists Association and co-chair of the Medication Management Work Group.
Hi, Mark Sweeney. I'm the Dean for the School of Pharmacy at Cedarville University and also co-chair with Ernie on the Medication Work Group.
Hi, I'm Danielle Baker, and I'm a PharmD candidate for 2018.
Hi, Corey Cronin. I'm an assistant professor at Ohio University in the Department of Social and Public Health, and I study health policy specifically.
They put the tall guys together, right? John Oberly, I'm a partner with the law firm of Ice Miller. I chair our government law group, and I have the pleasure of working with InXite and others around this room to do government relations and help with legal compliance and working with the state, whether it's Medicaid, the governor's office, trying to make sure that we're interacting with the state, because this initiative is so valuable for what the state is doing to make sure there's communication and growth and interaction. So we have the pleasure to help James and the team on those issues.
So that's where the tall guys end, right here. And
I'm big in stature.
I'm Chris McGill. I'm the Economic Development Director for Ice Miller. Mimic what John said, I'm also the guy that was presenting 2 meetings ago on funding options and sources at the federal, state, and local level.
I'm Jenny Valentine. I'm with Ohio University, the College of Health Sciences. I actually work in this building, lucky to come here today. And I'm the Senior Director for Central Ohio Programs and Partnerships.
I'm Beth Armstrong. I'm the Senior Director of Neuroscience at Ohio Health.
Janet Bay, I'm a practicing neurosurgeon and the vice president of neuroscience at Private Health. And I'm a friend of Chris Ann Gordon's, that's how I got into this. Happy to be here.
Ara Shahid, I work for Pain and Spine Center in Dayton.
Maria Asbury, I'm the Director of Quality and Programs for InXite Health.
Sherry Kent, I'm the Business Development Manager for Ohio for the Medical Advantage Group.
I'm Mark Reitnauer here representing the Ohio Optometric Association.
Sharon DeSize, I'm an account manager with InXite Health.
Hi, I'm Francesca Wagner. I'm the BD coordinator for InXite Health.
Darshan Vyas, I'm with Loud Capital, early stage investment commercialization VC firm.
Rodney Osmania, Strategic Systems, Director of Business Development and IT Health, Pharmaceutical and Medical.
Hi. My name is Tom Ferentz. My company is Care Management Network, and I work with providers to bring them value-based reimbursements.
I'm Dr. Belcastro Andrews, and I'm with ViaQuest, and we have a relatively new relationship. We do a lot of cross services between psychiatric and behavioral with developmental disabilities, so nice to be here.
And I'm Randy Leidy. I'm Dean of the College of Health Sciences and Professions at Ohio University.
And then that's everyone here. Anyone that's online, if you want to introduce yourself, please. Now, there's some of you out there. Anybody? Okay, well, I do know that there's several folks online as well. So welcome, everyone. Again, this is exciting that we have such great turnout, and it's really a full agenda that we're going to have here. Just to the level set, again, it's great to see a lot of familiar faces. It's great to see a lot of new faces here. Just a level set as to why are we all here, right? And I think everyone that's here, one way or another, touches healthcare and understands that what's happening from a market perspective is that there's a significant transformation that's happening, that has to happen, and moving from the left-hand side to the right-hand side here. So moving from a fragmented care setting where it's pay for service to more of a patient-centered, coordinated care, pay for value, right? So everything now is moving to value-based care. And with that, we're seeing some significant changes as far as how providers work and how they get paid. Significant changes. And several carrots and sticks happening to try to motivate and influence everyone to get from the left-hand side to the right-hand side. So with it, the rules of the game are really brand new for everybody involved, from the payers, the hospitals, the physicians, the specialists, the vendors that support the group. The rules of the game are very new. So again, we call it the new normal of healthcare. And with it now, it's all about looking at patient populations and being able to have the tools available to properly assess the risk across patient populations. Again, we know that 15% of the patients make up traditionally 85% of the costs. So the ability to identify these high-risk patients proactively and then do outreach and share information, build care teams, do whatever necessary to be proactive and preventative to avoid these costs and improve patient outcomes. And that's really the goal, is to improve patient outcomes. That's the key. And the challenge is that to implement value-based care, again, these are new requirements. When you look at this technology that's prevalent today, they weren't built to support the transformation to value-based care. So the EMR systems that the providers have, again, weren't designed to easily share information across provider systems. They weren't designed, around tracking information, identifying risk populations, and reporting on quality measurements. Those are all tenets of value-based care, right? So the EMRs today, again, while a lot of the providers today are relying heavily on their EMR solutions to help them meet the requirements of value-based care, the challenge is that they weren't built to do so. And in many cases, not only weren't they built to do so, the business practices are counter to information sharing. Health information exchanges, again, a lot of momentum, a lot of focus on exchanges, but again, they weren't designed easily for getting, when you talk about risk stratification, gathering all the data points to truly assess the risk of a patient, right? A lot of the efforts now are focused on clinical information, but we know you have to look at behavioral, environmental, and social indicators to truly manage that assessment. And then obviously the adoption for the HIEs, because the difficulty of how to get everyone connected is also a challenge. So again, to truly operationalize value-based care, there's a lot of things that have to happen. You got to fill the technology gap. You have to be able to collaborate, and coordinate, and bring parties together that now they have to come together because it's all about care coordination, right? So that's really the backdrop and for why we came together and started the Center of Excellence. And I got together with Randy and I talked about some past experience I had with the national security area and what we had to do to overcome similar level challenges and complexity. And one of the key things that worked is creating a Center of Excellence. And that's what this is. And the Center of Excellence, again, our goal is really to provide a shared platform or facility that isn't lobbying for a specific stakeholder, okay? The goal is to be able to bring everyone together and talk and communicate and share best practices and figure out how collectively we can develop systems and best practices to address the drive to value-based care. So that's the vision around the Center of Excellence. Who's participating in this? It's really, again, anyone that touches healthcare. So if you look at the complexity of this, that includes everyone from the states, right here in Ohio, major effort around state innovation model, innovation, multiple states, payers, the patients themselves, because it's all about patient-centeredness. Any of the providers, whether it's physicians or non-physician providers or vendors, they all have to figure out how are they going to do this together, right? And there's significant topics that have to get addressed, from interoperability to privacy and security to rewarding for value. There's a lot of things that have to be addressed, and it's got to be addressed together, right? By definition, care coordination is a system that coordinates the flow of information across participants with the patient in the center of this. So it doesn't do any good for different stakeholders to go and try to develop care coordination systems in isolation, because the whole goal is how can you coordinate and share information. Oh, not a problem, not at all. So these are major topics that are critical, and they help prompt discussions for the Value-Based Care Center of Excellence. And the goal with the Center of Excellence isn't to really have a lot of dialogue. I've been a part of a lot of these, these efforts and these initiatives where you come together and you hear a lot of say. You don't see a lot of action. And our goal is to get some things done. And the best way to get some things done is to develop this working committee, working group methodology. So the goal here is that anyone can identify topics that are important to each of you, okay? And based on everyone that's part of the Center of Excellence, and I think we have several, we have over 100 folks now, they can identify if there's shared interest in these topics. Those that have shared interest, they can create these working groups, working committees. Okay, and the working committees, again, the goal is to develop these working committees of cross-interdisciplinary stakeholders. So each, and then when we step through the working groups we've got, we'll have a committee that's focused on things like medication therapy management or chronic care management, and we'll have individuals, participants across the care continuum. Okay, that's important because, again, the goal isn't to lobby for one perspective. It's got to make sense. It's got to work for everyone, right? And too often than not, what happens is it's a big task that we're faced with. You can't eat the elephant in one bite. You got to take bite by bite and baby steps. So the goal with these working groups is what's our overall goal? Where do we want to end up? But what can we do to have quick wins? Right? So the whole methodology for the working groups is important, and the ultimate goal is, again, then to have a demonstration center and have set best practices that anyone across the country can actually learn from. Everything that we're talking about today isn't within these four walls. It's relevant across the country. Everyone's trying to figure this out. Okay, so that's the goal, and it's exciting to see where we started and where we are today. Today we've got 9 working groups at various. Some of them are further ahead than others, but we've defined 9 working groups: chronic care management, medication management, social service referral management, diabetic care, traumatic brain injury, infant mortality, behavioral health, quality measurements, BI analytics, and again, there's several other topics that continue to come up. So again, anyone that's here, if there's other working groups or other topics that you'd like to bring to the table, feel free to do that. If any of these working groups, as we start talking through the updates, that there's interest for you to get more involved. I know several of you there's some chairs and several participants now, but if you're not involved today and you want to get involved, please do. Okay, and it's an exciting opportunity for everybody. So that's where we are. I think that what we wanted to do, again, the goal today is we're going to give some quick introductions and some quick updates for various working groups, and then at the end I'm going to try to tie things together through the chronic care management, and actually try to provide a demonstration of some of the work we've done to date. Okay, so we're real excited. So the first one that we wanted to talk through is the social services referral management work group, and again, I'm pleased to announce Randy Lighty's the chair for that. So Randy, if you'd like to.
You want me up there, or do you want me to sit?
Come on up.
Oh, okay. Let everyone see you. Man, you're so demanding. Yeah. Well, social services referral management, really what this is about is that we often treat people with chronic conditions or acute conditions from a purely medical model, when in reality, for many of those people, the things that would help them the most are social services and resources they might bring. And so we're trying to look at this what I would argue is a pretty profound disconnect between healthcare provision and social services. And the attempt here is to look at ways that we might bring those two systems together in a little bit more seamless fashion. And so we started looking at this, and then also paying attention to the fact that if you sit right here where we are in Dublin, Ohio, and if you drive about an hour and a half south of here, or southeast of here to MacArthur, Ohio, you find very different healthcare and social service systems. And so there's not even like there's a uniform set of relationships to build. But what we really want to try to do then is come up with a way that a patient who presents with a health condition that's being treated medically would have some mechanism, some facilitated mechanism to connect with social services that would be of use to them. And can we do this in a way that's more efficient than it's done now? And so certainly today, when referrals are made, they're often done in a very inefficient way. Maybe a patient's handed a piece of paper saying, here's some place you can call, and you're on your own, those sorts of things. Very little in the way of follow-up, very little in the way of tracking, virtually no connection of records, and these are the sorts of things we want to try to address as we go through this. And so the charter that this group was given was to develop a patient-centered collaborative in which patients and their families have access to adequate, affordable, high-quality social services that enable them to achieve the best possible patient health outcomes. Can we do this in a way where we're providing access to high-quality services, that we can document improvement in terms of health outcomes, we can enhance information flow? I mean, have any of you known anybody close to you who's had a chronic condition? Yeah, I don't know about you, but my experience is when I've encountered this with my family members, often I sit there looking at them as they're interacting with physicians or nurses or therapists or whomever. I'm sitting there thinking, what would help them the most isn't what these people know. But what helped them the most is over here. And there's no conversation about over here. And so it's an attempt to try to address that. And what we want to try to do is really try to achieve 4 goals. One would be, is there a way to develop some sort of a common needs assessment tool that can be used when a patient presents in a primary care or specialized care situation? Some sort of an assessment tool that would really more broadly assess that person's issues than just beyond what's being presented. Is there a way to develop a social service registry, a registry of resources that would be available to all, and make that registry easily accessible? We also want to look at referral management. Can we come up with some protocols that would really drive referral processes for clinical and non-clinical resources in the treatment of chronically ill patients? Come up with some protocol that could be applied to do this, again, in some sort of a systemic way. And then can we somehow come up with mechanisms for sharing of information across very different systems that have different mandates and requirements for protection of information? Is there a way to begin to link systems so that all providers, healthcare, social service providers on both sides of the fence would have access to a common set of information? And so what we'll be doing, we had our first meeting in May, we have our second meeting next week, I think on Friday maybe, one day next week. Somebody will tell me before then what I need to do. I honestly thought this meeting was at 3 o'clock. I was just sitting down there, kind of about to drink a cup of coffee, and Francesca came and grabbed me and said, "What are you doing?" But what we want to try to do, what we have identified as initial steps, is to try to look at interorganizational routines, the ways that we can come up with routines, processes that cross organizations, strategies for connecting information in a more seamless, interoperational fashion. Can we develop bridges that would serve as boundary spanners? So it's things that we can put that would let us jump over the barriers that exist. And then, are there a set of decision mechanisms that involve meaningful, viable input from both healthcare and social services sectors? So what we did at our first meeting was we identified two subgroups. We thought, rather than doing this universally, let's choose a couple of issues. And so we thought, how much more of a consciousness you could get than the start and the end of the lifespan. So we thought we'd start looking at the issues of infant mortality and aging, and really try to understand both of those populations. And could we come up with some things? Could we do those things up above and see if we can apply those to both of those populations? And that would give us some interesting opportunities to compare and contrast and assess the effectiveness of what we're doing. Probably the first thing we want to do coming out of the chute is come up with some sort of a needs assessment tool that would be relevant to both populations, to begin to gather individual assessments that are currently used, understand what's being done now, thinking about how we can modify those, and then to create a shared knowledge repository of individual assessments. So let's develop some sort of a gathering of assessment tools, make those available, come up with a common tool that maybe builds on all of those, and then to begin to find ways to distribute this and assess what's coming out of this. And so if anybody is interested in joining the group, I mean, we're certainly open to more membership, and we're meeting July 8th, that's our date. At 2 o'clock?
I think 1 o'clock.
Oh, thank you. Okay, see, I'm always an hour. I was in Ecuador for a week and a half, so I'm still in Ecuador time, which is an hour behind us. So I was right on time, actually, if I was at the equator. Anyway, but we'd be happy to have you. I think I would argue, if we're going to do this value-based care stuff well, I think this issue of social services integration is really one key to doing that in a meaningful way. If you don't do this, we're not going to achieve all that we can. And so that's what this group is all about. And I think that's the last slide you gave me.
Yeah.
Yes, it is.
There you go. Thanks, Ray. Great. Next, want to introduce Mark Sweeney and Ernie Boyd. They're the co-chairs for the medication therapy management, or medication management working group.
Thank you, James. Let me give you the overview, and I'll toss to Mark for some of the specifics. In pharmacy, for years, it was considered to be a complete deal. If the physician wrote the prescription, pharmacist filled it, patient got tablets, end of story. what we're finding is 1/3 of the prescriptions are never filled. And that when they're taken, 50%, okay, 50% of the drugs are taken wrong. That has remained steady for 30 years. That is resulting in 10% of all our hospital admissions and 15 to 20% of all nursing home admissions because meds being misused. Now, interestingly, over the last 20 years, the payer system, the government, has figured out that we've trained these pharmacists for 6 years, they're now doctors of pharmacy, and yet we're paying them based on fill as fast as you can, please don't kill anybody. Now they're beginning to say, wait a minute, we have all this education, and in hospitals and long-term care, our relationship with physicians and other prescribers is a whole different game. Studies have shown that 95% of the time when our pharmacists make a recommendation in a hospital setting, that recommendation is taken. 5% of the time, the physician says, no, I want to do something different. But that relationship is there mainly because we've established that kind of relationship. The pharmacist has total access to patient records, and better outcomes have come because of that relationship. What's going on now with software that InXite has is that the difference between hospital and community practice has been access to records. Larry Schieber, as he sits here, was one of the first pharmacies in the United States to be recognized by a hospital as having an important role in patients not coming back to the hospital, specifically those patients that they're not paid for in the 30 days following a Medicare admission, that if they come back to the same thing, the hospital gets nothing. And so they gave Schieber Pharmacy access to the patient record as though he were an employee at Berger Hospital in Circleville, and that was nationally recognized. And it sounds like a small thing, it's not, right? Because we build barriers. I'm a doctor, you're not. I'm a pharmacist, you're not. We're a hospital, you're not. And so we built these barriers that kept us from doing our job. But when Larry got access, all of a sudden the national articles weren't written just because of the relationship. It was because Larry could prove that the readmissions to the hospital dropped like a rock. As a matter of fact, CareSource, who's been part of our group with the work group, has evaluated paying pharmacists for talking to patients again and getting them to actually understand the meds. And they are now saving, according to their numbers, $4 in avoided hospitalizations and ER visits for every $1 they pay our pharmacists. When Anthem did a program with Kroger pharmacists in Cincinnati, where again they paid pharmacists to do, what we did back in the 60s and 70s, stop and talk to patients, make sure they understood it. The A1Cs for diabetic patients went from only 50% of the employees of the city of Cincinnati hitting their A1C to 75%. What that means, reduced amputations, reduced blindness, reduced people falling off garbage trucks and other kinds of problems they were having, simply because the pharmacist was not just paid for the tablets, but paid to sit and chat. In this regard, what we're doing with InXite is really looking at medication therapy management, which is determined. Mark, do you want to carry on with a couple of the things we're doing in the committee and where we sit right now?
So as already said, we're basing on the premise that medications have a significant role in managing patients, and obviously that's a growing and expanding scenario in the United States. And as it pertains to the work group, what we've decided to do is establish some key goals related to education, access of information, constant challenge. We have a very siloed and segmented healthcare system, and it's pretty fascinating how segmented we have become to the point it actually does compromise care. And so by essentially improving access, improving education, assessing risk more appropriately, and even to the point of assessing risk for adherence, or non-adherence, I should say, assessing that risk is really important to driving better outcomes. You know, the interesting thing is I heard a physician speak one time, and she said, and she's down in North Carolina driving a very interesting model for healthcare, but like she said, the only place you can possibly get adherence information is from the patient, because you cannot get that from anywhere else. What you do not know is what they're sharing, and what they're borrowing, and what they're taking, and what they're splitting, and what they're throwing away. No one has that information in any database except the patient. So if we're not actually engaging the patient in a formal and appropriate manner, we will never drive improved outcomes. We have thousands of stories in pharmacy of patients who just did not get it. And, you know, at this point where drugs costing you what they are, when you drop a $1,000 pill down the toilet by mistake, it's pretty significant. And being part of that is very important. So what are the best practices? And so what we did as a work group, we pulled the group together and we're collecting project ideas. What we want to do is implement some pilots. We're targeting community pharmacies and community physician practices. Ernie already mentioned Shearer's Pharmacy in Circleville, Ohio, which would be a community-based pilot program. We're having conversations to see if we can maybe launch something, hopefully, with them. Comprehensive Geriatric Care in Westchester, Ohio is a long-term care geriatrics practice, and they actually run up and down the I-75 corridor. They have multiple facilities. They take care of assisted living patients, and so we're looking at implementing a pilot with them. Fagan's Pharmacy out in Indiana, Ruth Pharmacy down in Charleston, West Virginia, and then Waynesville Pharmacy in Waynesville, Ohio. And what we're doing is looking at practices that essentially would be easy to implement. Not a lot of politics, not a lot of infrastructure, some practice models that we can kind of get things rolling and test some ideals on what this looks like. CMS defines what we do with medications, specifically med adherence and medication reconciliation. So what we need to do is essentially run some pilots where we're empowering pharmacists to basically take ownership of med rec and med adherence as part of the model to drive outcomes. And that's essentially what we're trying to do. We're right now, hopefully by mid-July, have some things really firm and off and going. I think we're getting pretty close with comprehensive geriatric care as that rolls forward, hopefully. So, any questions?
Awesome. Great. Thanks, Ray. Thanks, Mark. So, you know, what we just talked about for the first two working groups, social services and medication management, are really critical when we talk about value-based care, because it's all about improving patient outcomes through better coordinating care and coordinating information. The social services side of it has really been left out in a lot of cases. There's been so much focus around health information exchanges and collecting clinical information, but again, to truly identify and reduce the risk for the patients, you have to be able to look beyond the clinical aspects of it. So that's why it's so very important. Also for the medication management and the pharmacist role specifically, you know, we looked at a lot of the value-based care models that have emerged, you know, to date, patient-centered medical home model and the episode of care model and the ACO model and several of these models that have come out. Again, at the core, they all require the same type of things. Okay, but each of them, they're incentivized. You know, the patient-centered medical home incentivizes the primary care physician to be the quarterback, right? The episode of care model is a specialist to be the quarterback, and too often than not, the pharmacist really hasn't been embedded in these models, and it's kind of strange because again, you know, the pharmacist is a critical care team member, right? The patients probably see the pharmacist more than they see the physicians. They're more geographically located. They should be part of these models. So, you know, in this medication management model, it's looking at, you know, what can be done to really embed, because, you know, the premise of care coordination is we're collecting data on a patient across multiple providers. What we're providing now is a view of information that many providers don't have today. Right? They don't know that my patient also saw this doctor who diagnosed the patient with this, prescribed these medications. So as we start breaking down these barriers and we start creating a unified care plan for a patient across providers, it's critical that someone, the pharmacist's role, is there to identify, well, you know, they didn't realize that these medications were prescribed, there's potential conflicts, that has to be resolved. Right, so it's really, really exciting, the model that we're talking about, both for the medication therapy management and then also for social services, because they're really key to these models. These other work groups are focused on specific types of patient populations. Okay, and Chrisanne Gordon can't be here today. I know Dr. Bain, you're here as well if you wanted to talk up on some of this stuff. Pinch hitting for Chrisanne Gordon is Sharon Desai.
You can call me in. I'll do the best I can to
and please,
honor her.
So I'm going to talk to you about the traumatic brain injury and post-traumatic stress syndrome group. Obviously, it's kind of going across a huge population. We've got kids playing sports, we've got young adults, we've got our athletes, our high school students, we've got normal athletes like in the NFL, basketball, all being affected, our elderly, everyone's susceptible. I myself have had 2 concussions and I'm no athlete. And that may explain a lot of the things that I do. Maybe someone needed to do some early diagnosis for me. One of the things that I think is really interesting with this group is that one of the factors that they have is only 8 to 10% of the healthcare providers are trained to treat traumatic brain injuries properly. So that's a really low statistic for something that I think we're seeing a lot more of. People are becoming more aware of it. You had the concussion movie that came out recently. You see it in the news with the NFL. Our kids, if you have any kids that play sports, they talk about it all the time. So I think that's pretty interesting. We don't have a lot of people for that. Left untreated, lots of secondary things that happen. People that get into drug use, have mental health issues, lots of other things can come out of that. So it's a really important work group, I think. So as James said, Chris-Ann wasn't able to be here. We've got some partners here working for us and some different group people. The Ohio Optometric Association, so things that you don't even think about. The Ohio Health Group's here, Dr. Bay, and feel free to jump in at any time. You have way more information than I do. Very honored woman to be here for us today. Just the awareness, the project charter is about awareness, diagnosis, and treatment for this. Just kind of bringing it up to the forefront. There's not a lot going on to really get it up there. And so our goals are looking at this early diagnosis, treatment by telemedicine, which is really important. Again, a small percentage of people treating, lots of people in different areas that don't have access to that treatment. Awareness and communication, which I think it's starting to get out there a lot more. People are seeing it a lot more. And then, of course, long-term treatment plans so that we can get people in. And social services is a big part of this. What social services, medication management, all these things really feed together to create that, holistic view of how we can treat them. So we just had a meeting recently as of 6/21. It was really our first real meeting. We were meeting with Chris-Ann prior to that. And one of the things that we talked about was getting this knowledge repository together. Start with all the data first. What are people doing? What are the high schools doing? Dr. Bay has already brought us in a sheet of the software that they're doing to collect data for these kids. They do complimentary screenings for athletes starting at 10 years old, which is a great way to get baselines for these kids. Probably information we don't have a lot of data on, so that's really good to have. Just improving these outcomes, what kind of technology, what kind of people, what kind of processes do we need to do this? And then sharing these assessments. How can we pull all this data together and make sense of it? What are we doing with the data? How can we figure out what's working, what's not, finding those trends? So lots of information that we're looking for to gather sort of the best practices. Let's get in there and diagnose people early, find out what we need to do, what's working, what's not, and kind of move on from there. We're going to schedule a meeting in August, and again, we'd love to have anybody, if someone from social services wants to join in and help us. I think that's a big part of it, so that's what I have on that. Dr. Bay, anything that you guys want to add?
I'll just comment that, one of the early things, the struggles is to get scope with this kind of thing, because we're talking about illnesses as diverse as mild concussion, going all the way to Chris-Ann's real passion, which is severe head injury in veterans that have military injuries that lead to post-traumatic stress, unemployment, suicide, years of dysfunction and cost to the whole system. We decided to focus on the milder end of the spectrum and young athletes first because there's more data there. And I think there is some real opportunities to get best practices out. So we're going to start with that and probably end with the veterans on a different end of the spectrum. But this is a great opportunity to, we have the awareness. I think people are engaged in the community, and now we just need to get the information out there. So we're in the early stages of gathering the information.
Yeah, and if, like I said, she's already committed something for us from some groups and some high school names that we can start reaching out to. If anyone has anything to share, we'd love to have that. So thank you.
So again, it's exciting to see the groups come together and how important these topics are. And there's obviously, across the multiple working groups we're talking to, we probably already see there's a common theme that's happening. right? So a lot of it has been, data-driven decisions have to be made. You need the data, you need the questions, and for, for assessing traumatic brain injury, there's a lot of different providers, but are they learning from each other? Are they asking the same type of questions? Are they sharing outcomes and trying to tie, care pathways and care plans to improved outcomes? And is there anything there? So I think a big part of this across a lot of these working groups is initially, the questions that we need to ask to identify the needs of that patient and to properly diagnose that patient. What are those questions? Because it starts there, right? Getting that data together, again, from that, being able to help risk stratify the patients. There's been a lot of effort on looking back in hindsight and saying, the infant mortality working group is an example. A lot, major issues across the country, especially here in the state of Ohio, right, where infants under the age of 2 are dying. A lot of research has been looking back as to why is that the case, right? So if we had those data points in advance, could we proactively identify the highest risk patients and put teams in place and improve to be preventative? I think that's the common goal. So I think that the collection of creating a shared knowledge base is an important part of this. Whether it's for social services or whether it's for TBI or infant mortality, just collecting the shared knowledge base, being able to track around the care plan and track adherence to that care plan, and then report on that. And with value-based care, again, the name of the game is very different, right? It's all about outcomes. It's all about improved outcomes. So, the next working group that was developed was because now it's all about how can you track improved patient outcomes, because ultimately incentives and reimbursements are going to be heavily tied to that. So we have a work group around quality measurement. We have Sherry Kent from Medical Advantage Group and Maria that are co-chairs to this. I don't know.
Sherry's going to present.
Got Sherry?
Thank you. So Maria and I spoke earlier this week, and the advancement of this group relies a lot on the feedback from all of the other subgroups. So until we can gather that data and help each of you with your measures, whether they're identified yet or not, whether they're going to be consistent with measures that are already out there, that we can accelerate the reporting that we get back from that, is yet to be determined, right? And we are very willing to work with each of you to figure out what is the best method to expedite what you choose in your group. So we've identified the problem that we need, valid and appropriate measures. We want this to be real, not an exercise. So they're critical to the development of evidence-based practices. We all know that. Our work group will advise or serve as advisors to each of the other groups, like I just said, in identifying existing quality measures when possible that are relevant to the work that you want to do. If we need to reinvent the wheel in some cases, let's get creative and do that. Our charter is to support those outcomes and being able to help measure, collect, analyze, and deliver this in a meaningful way. We want to standardize and support the process and outcome measurement activities from each work group by working with multiple pilot groups to the collection and analysis and reporting of those measures. So a lot of repeating themes there, but that's what it's all about, is collecting it, analyzing it, and making it be relevant and meaningful. So we don't have our next meeting scheduled at this point in time. We want to keep our finger on the pulse of all the other subgroup activities. So you can reach out to either one of us through the contact information at InXite and be able to ask us for any help or guidance that you might need. And I can tell you that I have access to lots of resources within my company that has worked for probably the last years on advancing quality scores, whether it be HEDIS, DQRS, those types of things. And that's one of our strengths is the aggregation and analysis of that data. And obviously, Maria has many resources available as well.
The only thing I would add is we're a tiny team. We'd love to do more and be integrated into all of your efforts. And so if there's anyone who would like to join the quality metrics team officially, we would love that as well. We're actively recruiting anyone who might be interested in this aspect. Everyone who presented so far, and I'm sure everyone who will present next, all mentioned data. As you can imagine, that's going to be the driver of the decisions that come out of all of the work that we're performing. And so we'd love to be a partner to you in identifying what the best measures might be. Like Sherry said, whether they already exist in the literature or if there are things to still be identified. We'd be happy to help work with you on outcome measures or process measures, whatever you think is most appropriate to the topic that you're working on. So please reach out and consider us part of your work group.
Great. So again, a lot of great work's being done in the individual work groups, and we kind of talked about how there's a lot of, gray area. There's a lot of overlap between different working groups. And the reality is these working groups ultimately are going to come back and tie into each other, right? So, the analogy I often use is it's like dropping a pebble in the pond, right? And that ripple effect takes place till all the edges of that pond are touched. And everything from whether it's the medication management, whether it's social services, whether it's proper clinical diagnosis, whether it's the pathways, those are all things that have to work together in a coordinated fashion to ultimately meet the common objective, which is improving patient outcomes. I'm the chair of the Chronic Care Management Working Group, and we put a lot of time and effort looking at chronic care management and what it's all about and what's the issues and challenges. And a couple of things, as far as the business problem, again, 1 in 4 adults have 2 or more chronic conditions. 7 of the top 10 causes of death in 2010 were from chronic diseases. Again, when you look across, where the spend is in healthcare, again, 15% of the highest risk patients make up 85% of the costs. Those highest risk patients have 2 or more chronic conditions. So managing chronic care is very, very significant, very important. It's recognized by everyone. So CMS said, okay, we've got the PCMH model that incentivizes the primary care physician to be a quarterback and develop coordinated care teams. We've got the episode of care model that incentivizes a specialist that leads an episode to be the quarterback for that team. We have models like the ACO model that incentivizes communities of providers to come together to, again, help improve patient outcomes, right? Except the reality is that we're barely scratching the surface. CMS, Medicare identified 35 million patients that have 2 or more chronic conditions that should be seen through one of these systems. And today, we're barely scratching the surface. I think that at the end of 2015, less than 100,000 of those 35 million patients were actually serviced. Okay, so for us to really move the impact, this is really, really important. And with that, CMS in January of 2015 said, okay, let's, similar to what we do with PCMH and episode care and ACO models, let's provide incentives to motivate physicians to again identify high-risk patients and be proactive and preventative. And that came out, it's the CPT code 99490, which again is designed to incentivize providers to be proactive. Across your patient population, identify those that have 2 or more chronic conditions. Okay, for those, then we want to be proactive and preventative. So, spend at least 20 minutes of non-face-to-face time. So the times that the patients aren't coming in to the office, what can be done to, again, improve outcomes? What can be done to make connections, connect the dots? What can we do to help interact with the patient, identify what are they following their care plan, what issues do they have, what can be done? So the goal of this is to incentivize behavior, right? And what's nice about this is it doesn't restrict it to a primary care physician, it doesn't restrict it to a specialist, it really opens it up. right? So, it opens up as to if you're seeing patients and you know they have 2 or more chronic conditions and they're currently not being managed in a proactive way, the ability for you to extend this service out. So the intent is really great. And, obviously there's strict requirements for a, provider to be eligible, for the patients to be eligible, what has to take place here. The good and the bad. The good is it's value-based care with a really nice, neat fence around it. Okay, so what's nice about this is that unlike a lot of these other models where a provider has to invest a lot of time and effort and wait a period, usually 12 months or so, to see if there's going to be reimbursements made. In this model, that's not the case. So in this model, it's monthly. It's recurring monthly. So the ability for a provider to identify a patient with 2 or more chronic conditions, do what's necessary to meet the requirements, bill, and they get paid the following month is great, right? And the incentive, this is a new revenue line. It doesn't take away from the current pay for service. It's brand new revenues coming into practice, right? And it's significant, right? So in many cases, again, depending if it's Medicare, Medicaid, or commercial, the reimbursement per patient per month might range from $38 to $55 per patient per month. Okay, so if you have a practice that has 1,000 patients or 2,000 patients, that's a nice recurring revenue stream that comes through. So the good news is it's a great incentive. It's trying to incentivize providers to do the right things, trying to, again, address this high-risk patient group. Again, the bad thing is that less than 100,000 providers in 100,000 patients at the end of 2015 out of 35 million were being managed from this. Okay, so we spent a lot of time saying, why is that the case, right? The working group is, our goal is to really understand what we need to do to operationalize value-based care, and CCM is, again, one great example of value-based care. So what we've done to date is a lot. Okay, we've done a lot of market research. We've talked to a lot of different parties, from the government to payers to hospitals to primary care physicians to specialists to you name it. We've talked to a lot of groups about what are they doing, what aren't they doing, and why aren't they doing it, because the incentive's so great. We identified what those critical challenges are, and as a working group, the goal is to implement technology and people and process and introduce models to remove some of these barriers. Okay, so that's what we've done to date. A couple things here is that because CCM and the incentive dollars is so great, there's a lot of noise that's coming out in the marketplace right now, right? You have people that are hanging up shingles saying we have a CCM solution, we have a CCM solution, we have a CCM solution. And I've talked to providers where they've been using these solutions with very, very marginal impact, if any, right? Impact at this point. So the challenge with this is because it is such a great incentive, there's a lot of providers coming out here with really not complete solutions. And everyone's focused on, hey, we can help you meet the 20 minutes that you need to bill and get paid for this service. And everyone's focus is on what can we do to meet the 20 minutes for you to bill and get paid for this service, okay? And the reality is, we know that it's not about meeting the 20 minutes so you can bill and get paid, right? The real goal is improved health outcomes, right? And unless the 20 minutes that you invest translates into improved health outcomes, guess what? It's going to be very short-lived. Right, so we took a view of this as to, again, we certainly understand minimally what do we have to do to work with providers to bill and get paid for CCM, but the bigger eye is what do we need to do to leverage that incentive to ultimately improve patient outcomes. That's what it's all about. Okay, so I'm excited about the stuff we've done. We started with, again, looking at what the workflow requirements are, and again, with CCM, you have to identify patients who are eligible. You have to enroll them. There's a requirement to For that, it's got to be kicked off with an annual wellness exam. That has to, during that wellness exam, CCM needs to be introduced to the patient. The patient gets to determine and provide consent if they want to participate or not participate. Right? They don't have to participate. And a lot of this stuff has to be documented in a certified EMR. There's a whole notion of a shared care plan. So again, being able to take this high-risk patient, create a care plan that can be shared easily across that patient and other providers. You hear a lot about the 24/7 access to that shared care plan. And then you hear a lot about 20 minutes has to be spent by an eligible care coordinator or navigator. Right? And that time has to be recorded and documented. So a lot of requirements around CCM for you to bill and get paid for it. Okay? And there's a lot of folks kind of focused on these parts of it. Reality, again, is the goal is improving patient outcomes. Right? So to ultimately meet that goal, there's much more that has to be brought together. Right? You ultimately, again, the shared care plan talks about, again, the whole notion of having a shared portal. It really drives to the forefront the need to have this interoperability management. Because if this is going to be a patient-centered system, when you're bringing in information across providers, well, as a patient, I may interact with a primary care doctor, I might interact with a large hospital that has large, very sophisticated systems. I may have pharmacists that have a different system. I may have dietitians and chiropractors that don't have a system. Right? They all have very different systems. They all have information on me that has to be brought together. So the shared portal, how you manage the flow of information, how you can ultimately create that unified view of information, knowing that the technologies today don't make that very simple, right? To do that. But the whole notion of creating a unified care plan, and the care plan is really the keys to, is the patient's health improvement going to improve or not? Are they tracking that? So as part of that, being able to have some kind of health performance tracking, so that if you are able to bring data together, how can you measure if it's making an impact, a positive impact to that patient? Right? So you have to have these things in place. When you talk about care coordination services, there's a lot of talk about a navigator, but okay, spending 20 minutes, you're going to spend a lot more than that. So what else does that care team, what do they need consist of? Whether it's a pharmacist, whether it's community health workers, there's a lot of work that has to be put into this over and above the navigator that's often talked about, right? The documentation, a workflow system, so that how can this data, this patient, all these providers, how do they coordinate tasks? How do they coordinate the sharing of information? Right? These things have to be discussed and have to be solved. Otherwise, what's going to happen is 3-4 years, a lot of money's been spent and not a lot of improvement of outcomes are going to be made. Right? When you talk about care coordination services, we talk about assessments. But again, doing the assessments, having a process for basically developing care pathways that can be followed. So it isn't spend 20 minutes. It's spending 20 minutes of the right things to improve that patient's outcome, right? So the TBI working group, the infant-mortality working group, it's okay, if this patient has TBI, what can we do? Should we refer them to other clinical providers? Should we refer them to other social service providers? Are there certain activities or things that we can interact with the patient on to improve their outcomes? Again, it's a whole person type perspective that has to get done. So, all of this stuff in reality is not talked about in general. And these are things that we're really focused on trying to bring to bear. And again, we spent a lot of time understanding some of this can be addressed or aided with technology, but technology is not the solution, right? There's got to be technology and people and process. So we've spent a lot of time looking at, again, what are some of the key issues that as a working group we wanted to address. And we spent a lot of time working on some of this stuff. The key that stands out is around obviously interoperability, right? You gotta get information, you gotta make it seamless, you gotta make it easy so that a provider isn't managing multiple systems. It's easier to bring information in. The workflow and the tracking of the 20 minutes, the care team composition, defining pathways to follow. those are some of the biggest areas that we wanted to kind of address as a group. And in doing that, just like the goal here to bring people together isn't to reinvent the wheel each time, we took, again, the stance of saying, okay, this can't be unique to healthcare. And we looked at other industries that have had common challenges in the past. And we said, what have they done to solve these problems? And so we've done a lot of that. And if you think about, financial services, you can be in a different country, you can put your ATM card in, check your balances and move money around. Can't do that with healthcare, right? You can look at supply chain corporations where they've put in vendor managed inventories, where the suppliers put in their availability and their quality and their cost. And the companies can select the best provider with availability and cost measurements. When you talk about value-based care, guess what? It's all about making sure that the patient you're referring, that provider has high quality scores, low cost scores. Everyone's going to be measured against that. When you look at national security, again, there's been a whole notion of how do you bring data together and get a full view of that individual to assess the risks of threats. So there's a lot we can learn from, and that's what we've done with InXite. So what I'm going to try to do here is show you some of the fruits of our labor. And again, it's not complete. It's absolutely still a high work in progress. And one of the neat things. One of the neat things that I downloaded just last night was an app. It's not our application, but it's an application to display things on my phone on the screen so everyone can see it. But it's not working very well. So it may not work. So let me get started with what we've done. Okay, and the first part of it, when we talk about the requirements, is there's a base level of capabilities that, when you talk about a care coordination system, there's base level of capabilities that really has to be there, right? You have to have the ability to deal with interoperability issues. Okay, I'm allowed to talk to you. And again, we looked across the other industries about how do they deal with interoperability issues. Okay, and national, I had the good fortune to be able to work in the national security space for over 10 years, and working with Department of Justice and Homeland Security for their public safety, national security initiative. And again, they had to deal with this and they had to solve those problems. And they collected information from every type of business, every type of agency out there. So what we did is we looked at their methodology and we applied it here. Again, I'm not going to spend a lot on there, except the interoperability framework is similar to what's enabled today, where large agencies, small agencies, public safety, law enforcement, commercial, financial, all this data can come together, and it's operational today, right? So these things are in place, and the important thing from our interoperability side is we can manage that. And you need to have that in place so that you can have this patient-centered, which is Bethany Smith as the patient here, and a care team approach. So this care team isn't all the providers in a specific health network. It's the fact that one care team member might be part of Ohio Health, one care team member might be an independent physician, one might be an independent solo dietitian, whatever it might be. All of them, their information has to be brought together. So the notion of having a care team approach where we bring data together, everyone can view that, and part of that is a unified record, so that across the different providers you can collect data and have one record. So more very analogous to a patient-centered EMR. So now in this case, this is one record that includes all relevant information, but it's fed not by one EMR system, it's fed by multiple providers, right? So the ability to have this unified record, the ability to create a unified care plan. So again, similarly, now I go to the optometrist to look at my eye issue. They identify what the issue is, they develop a plan of care to fix my eye issue. I go to a podiatrist, they look at my foot, give me a diagnosis, give me a plan of care. Very seldomly do those physicians know what the others have prescribed. And there's a lot of issues. So the ability to take the individual care plans, and in this case, there were multiple care team members representing multiple providers, bring that together so there's one unified care plan. Here's all the meds that were prescribed to this patient across all these providers. Okay, and be able to just bring the data together is the first challenge, right? So being able to have that, and you have to then, again, that care plan is significant because if the providers are diagnosing the patient, creating the right care plans, and if the patient is following those care plans, then the health should improve, right? So it's important then to basically track to that care plan and make modifications. So how do you do that, right? So this whole notion of this health score was developed where all the providers that service a patient can define any areas of risk. Okay, that can be clinical measurements, that can be, I want to track behavioral non-clinical type of measurements. I have to track patient adherence, right? Because the goal is the patient has to get engaged to basically proactive for event. So the health score, what's nice about this is it allows providers to basically define criteria that they want to track. And as we get data, and we can get data from everyone, and I'll demonstrate that. We can get data from the patient. We can get data from the provider. We can get data from the specialist. We can get data from the payer. As we collect data, we plot the information onto the health score. And if data falls within this green band, then that's an acceptable range for these specific measurements. Okay, so now the goal is any of these outliers, again, when we talk about data decision, look at the outliers. Those are the problem areas that care coordinators and care teams need to address, right? So one of the big problems right now is you just don't know what you don't know. We work at the Federally Qualified Health Center, 10,000 patients, 2 care coordinators. Who are they going to focus in on? Which patients are in the most need? This health score helps them to basically manage that and track that performance over time, right? So having that is very important. So this ties directly in with the care plan. And now the goal is, again, measuring the outcomes against that care plan. And as part of that, you have to engage the patient. So patient engagement is a big and very important thing. And this is what I can't show you the live because we can't get this to work, but I can show you what the application looks similar to. It's actually a little bit different. If everyone wants to see it afterwards, I'll show it to you here. But the key here now is that unified care plan that's developed. How do you engage the patient? The ability to basically take the care plan and push out weekly alerts to the patient, right? So those weekly alerts will say, based on your care plan, this is what you should do. You should take these medications. You should manage these activities. You have a follow-up visit. Track these metrics, right? So being able to just drive off the care plan the alerts back to the patient, but also it's about care coordination and collaboration. So now the ability so that it's a two-way communication. It's not just a one-way push saying do this. It's a two-way communication. So did I take my medication? Yes. In this case, no. Okay, and what's important now is that you're not doing something that's defined in the care plan. It's really important to understand why and get that information back to the providers, because if you're not, that's higher risk, right? So the ability to basically to collect some feedback to say, well, this is too expensive, I just can't afford it. I can't do my follow-up visit because I don't have any transportation for it. That information is critical to be brought back and submitted. And as that information is pushed out and brought back in, being able to have a mechanism to reward or incentivize the patient to even want to respond, right? Because this is a change in behavior. So as part of that, building in everything's loyalty programs, right? Your Marriott rewards and your gas cards and your grocery cards, it motivates changes of behavior, right? Same thing here. So now, building in a loyalty system so that based on the patient to pick up and respond to these alerts, based on them saying, yes, I'm doing this and I'm meeting these care plan milestones, then, to the payer, that's a lower risk patient. They're engaged and they're doing things, right? So this point system allows them to basically track those points, which, like any other loyalty system, turns into dollars, that those patients can use those dollars what they want to use it for. They want to use it to buy things, great. If they want to use it to pay for their deductibles, great. And that's an important thing that when you talk about chronic care management, one of the intent is really strong. There's some gotchas, right? One of the gotchas is the patient still, in many cases, has to pay their deductible. So think outside the box and say, how can we manage that so that the lower risk patient is properly incentivized? That's an important thing here. All of this information then, again, will go and be fed back into to the patient navigator, care coordinator through the system. Okay, and what's nice about this is being able to have a two-way communication. So when you look at the EMRs today, one of the challenges that from the providers is, man, it looks like it was built in the 70s. I go to my work on my EMR, it looks like this. And if you look at the patient information, it looks like this. And then I leave my provider setting and I go on to Facebook and I go on to LinkedIn and I go on to Twitter. And it's like, oh man, this looks a lot better than that. So being able to gather this information, one of the neat things we've done is taking the likeness of Facebook, but creating that specific in a HIPAA compliant manner to this patient and their care team. Right? So if the patient now wants to say, if I can do this. One second. So if the patient is coming in and saying, you know what, I can't take my medication and I can't make my follow-up visit, and they submit that out. And they can talk about the reasons why they can't do it, and they send it. And it would be really cool if you could see what I'm doing on here, but you can't right now. But ultimately, that information will actually be fed back to the system and updated here. And what's nice is that it's a two-way communication, so you can actually communicate similar to Facebook. So if they can't make their follow-up visit because I don't have transportation, they can actually, the navigator can say, let me set up transportation for you. If they can't take their medications because they can't afford it, now the navigator has a mechanism to get that. I'm going to interact with the provider, or I'm going to change the medication, do something to resolve that, to do that. So having those kind of capabilities is really important here. So this core capability is available. When you talk about chronic care management, again, tying this back to chronic care management, there's specific things that have to get done for CCO. Okay, so it starts with, again, the enrolling the patient. In this case, Bethany's already been enrolled. So the provider's already done their wellness visit. They've talked about CCM, and they've received the consent form that's tracked and stored here as well. Okay, so that's the first, the enrollment's the first part of it. The ongoing part is the care services. And one of the neat things, again, is that this platform and this information that's available through the platform. So if you look at, again, at the care plan, and you look at the care plan summary here, okay, and it has diagnosis and has the medications for Bethany. And if you look at the provider EMR, right, it's got to be synced, right? So if information is added in the portal, it needs to be updated in the practice EMR. If the information is updated in the EMR, it's got to be updated in the practice. right? Steve, you talked about a lot of the need to do that block, because without that, you're going to have a lot of resistance to get that to manage. So the information here is the EMR view of that information. The information here is the same information in another view. And when you talk about CCM, again, it's about tasks. So developing a workflow so that for this patient, the annual wellness visit was completed. You know what the main issues might be, and you can create a task plan for the care coordinator to manage. So again, it isn't 20 minutes of anything. It's 20 minutes of directed effort that's required to improve the outcomes of that patient. Right? So this is really neat, where you can create, do things like, in this case, it's going to be, one of the tasks is I want to review the care plan with the patient, make sure they understand it. So through the system now, as attached to that, the timing and the tracking, you notice up here, manages the recording of that event. Okay, and it's critical to track that. And it brings them right to their care plan. So now the provider can interact with the patient to say, let's go through this. Here's the problems that we have, here's the goals, here's your diagnosis, here's the medications that we're prescribed to. Okay, and they can interact. Are you doing this? Are you following this? What issues and what challenges are you having with it? And they might find things out like, I can't take this medication here because it just makes me feel sick. So I'm going to, the care plan says I should be taking it, but I'm not taking it. Okay? Being able to track and record that here. Being able to say, well, yes, I am taking this medication, but it's not what you have listed. I'm not taking tablets. I'm taking it via solution. Okay, so being able to interact, capture that information, and then ensure that that information is brought back to the EMR, right? So now looking back, from the prescription side, this supplement, this medication that the care coordinator said they aren't taking it, now it's updated, it's inactive here. That's an important part of it. Being able to, you look at this medication, which we changed it from tablet to now we're taking solution, those updates can be made. So that talks about the seamlessness of this, and it has to go both ways. So if on this side of it, the provider said, I'm going to go to medical problems, and I'm going to add, in my EMR, I'm going to add a new medical problem, asthma. And they save that. Okay, the ability for that action that's being done at the provider, at their EMR, to basically be reflected in the care plan is very important. Right? So again, having that two-way interaction and two-way communication is absolutely very important. That's part of the system, is being able to have that piece of it that's done. And with the care groups, again, a lot of the groups now are determining pathways. So if it's a TBI and the patient is identified, here's a question to diagnose it. Is it mild TBI? Is it just traumatic brain injury, whatever it might be? And if it is mild TBI, what are we going to do? So there's a series of tasks that can be created by the working groups, right? And for the diabetic working group, they can say, I'm going to create a pathway, and that pathway is going to include these kind of things. Or for traumatic brain injury, I'm going to create a pathway. It's a list of tasks for the provider to basically manage. Right, so all that stuff is really important. That's now tracked and managed through the system. When you're done with an event, being able to record that back into the EMR. Right, so here we just again finished this review care plan with patient, and we know we just spent 3 minutes reviewing that, and who completed that, and any notes that were provided is there. That's the billing stuff. So again, a lot of time and effort has been on making this interactive communication from a big picture, and ultimately that's going to result back to the billing reports and ensuring that gets done. But that's if you're only addressing that in this fashion, can you really ultimately improve patient outcomes? So that's where we are right now. Again, we're excited to work with Ernie, Mark Sweeney, and several other working groups. We're actually piloting this in several areas, several opportunities right now. Okay, and again, this is the starting point. And what's nice, again, it was built to be interactive, right? So there's a lot of what we call point solutions out there, right? We talked about a really nice annual wellness tool that can capture that and do some risk stratification at that point. We're talking now about embedding that capability as part of this. There's a lot of population health reporting tools where they can slice and dice things, embedding that as part of this, right? So it isn't about, it's not one size fits all, but it's being able to take systems and create one coordinated system. So that's a little bit about the platform. There's a lot more there, but in the interest of time, we'll just move on. And so from a technology side, that's what we've done. From a process perspective, we spent a lot of time looking at the interactions that have to get done to improve outcomes. Right? So again, having a patient navigator that is the liaison between the patient, their provider, and the care team, and having a support group that supports that patient navigator is another thing that we kind of spend a lot of time working through. So we're excited about the progress we've made. We know there's a lot more we want to do. We absolutely welcome anyone's interest to participate, to pilot it, to kick the tires, whatever it is. That's what we'd like to see. The other working groups now, as you see, everything kind of plugs in to being able to capture data, create these pathways. So the diabetes working group, behavioral health working group, we have a BI analytics working group and infant mortality. Very similar efforts going on. Anyone that has interest to participate in any of these working groups, please let us know. So that's the bulk of today. When you talk about the organizational piece of it, one of the things that we want to implement now is this Center of Excellence Demonstration Center. Okay, and what's neat about this is it's intended to be a physical demonstration center where you may have an EMR provider, or you may have a telehealth provider, or you may have someone that's that's specific to your situation, and you want to basically have all the groups work together to make it interoperable, to make it seamless, right? So this demonstration center that's what the intent is, right? So your vendors or yourself can come in and say, let me replicate my environment in the demo center, and let me see how I can exchange information with you, and how I can exchange information with you, right? And this is going to be real exciting. We did this again on the national security side, and this became basically a national demonstration center where vendors can come in and work with other vendors to test and work through issues and interoperability. Okay, so anyone that has a technology, or your vendors that have technology, they're welcome to come, load their software, their capability, and create a working group to talk about, okay, how are we going to get these systems to be interoperable? How are we going to do this? Because everyone's faced with the same challenges. And from that, you're going to get a lot of partnerships, you're going to get a lot of improved capabilities, ultimately translate improved patient outcomes, right? So absolutely, we welcome any of you to introduce this to your vendors or to yourself. Come in and let's recreate the environment, let's do this so that we have a working demonstration center. And a lot of the infrastructure is going to be provided, so the vendors just need to come, they load their software in, they work with the teams, and they can go. Okay, so that's the goal, and I think that next meeting we'll do that. The other organizational update is there's a lot of funding opportunities that are coming about. Okay, lots of them. I know, Maria, do you want to spend a few minutes on
Sure.
on this?
As James indicated, there's a strong belief that there needs to be changes to our existing healthcare system. There's not a lot of evidence yet about what that best model might look like, and so there is an extraordinary amount, in my opinion, of grant dollars available for research to start to put some data behind the various models and pilots that we've been talking about, and put some evidence forward that will tell us what the better models might be and what direction we should start to focus in. So The problem that I found is that there are a multitude of sources. Trying to keep your eye on all of them at the same time can be time consuming. The even bigger problem is once you know about it, the turnaround time for the letter of interest that's required is often very quick. And so if we don't see it quickly and respond to it quickly, we lose the opportunity. So I thought of all the other things that this group is doing, we have this shared need to learn more and fund those learnings. And so anyone who might be interested in being on this kind of, grant think tank, if for lack of a better word, I'd love it if you would contact me. I can keep you on a list, and anytime any of us see something that looks relevant. All of the work is moving toward an integrated system. So as you can imagine, the grants are looking for groups that show a pharmacist, a physician, community-based insurance carriers. They really want that blended model because the belief is that's where our solutions are. And so I think this group is perfect in terms of its makeup. Anyone who'd be interested in kind of being this front line and be watching for these and pull together a quick brainstorming session about, is there a topic that we're equally interested in that we'd like to pursue and put a letter together, then we should be able to turn that around more quickly. So please reach out to me at InXite and let me know if you'd be interested in doing that, and we can try to start putting some efforts into that, see if we can respond a little more quickly than we can individually. Thank you for your time.
And this is great because a lot of the grants are coming out basically are ultimately asking for the same type of thing.
Right.
And we've had the opportunity to basically start writing for some of these grants, and in doing that, we're creating relationships, we're thinking through how would we respond to that, and whether, these grants are highly competitive as well. So being able to have this predefined and have a group of folks that already are working through how we would respond to that could probably be applied over and over and over again. So absolutely, I highly recommend for everyone to get involved with that. Again, there's absolutely strength in numbers and being proactive and working together and identifying solutions, but also funding opportunities to get this moving forward. We want to do that. And then the other one is the staffing side. So again, everything from the Center of Excellence to date has been volunteers, right? So we've had a lot of great volunteers, the working groups, the chair people have been a lot of volunteers. It's grown significantly. We've got a lot of movement and traction, and it's really, starting to take a life of its own on. And, the goal now is to say, okay, what can we do to really start formalizing this, right? So, Randy and I, we have another daytime job, right, outside of trying to promote this, bringing in an executive director, bringing in project managers that can work with the task groups, bringing in folks on a marketing side of our outreach, and whether it's full-time folks or just your organizations, right? All these everyone that's part of a company, they contribute marketing support, or may just contribute planning support, project management support. Please, again, please get involved as part of that. Okay, and actually we're not too bad as far as time. Let's see. Last is just the next step. So again, this forum where we try to bring together everyone and give updates to the different groups, we try to do quarterly. So I think the next meeting that we want to have this forum will be at the end of September. I think it's September 29th is what the target date is, and we'll get everyone out there. In addition to that, as you've seen already, the working groups are established, meet between. Right, so everyone has different schedules for when they want to meet. So the medication therapy management, social services, TBI, those individual working groups are also being managed. So any of the working groups that you want to get involved with, let us know, and we'll get you involved with it. Okay, I know everyone would like to do that. If you're unable to participate in these working groups, then September 29th, again, we'll have another meeting here. Hopefully, my goal is that demonstration center will be a very, I think it's going to come across very well. So be able to work with other systems and other vendors to bring them together, figure this out so that now we can actually show more interoperability between different systems. And I think that's going to be the goal. And then also the updates for the pilots. We have several pilots we're doing right now, and then the status of the work groups. So that's all we had. Again, I want to thank everyone for your participation. It's great to be able to have such momentum and have you spend as much time on your day doing this. I guess last is I'll open the floor if there's any questions or comments. Go ahead and open the floor to that. Yeah. We did a really good job or really bad job? You always have questions.
Since you put me on the spot, I'm happy. Are you looking for any other subcommittees?
Oh, yeah.
Or,
absolutely. I mean,
Chris and I were talking about, should there be a governmental committee kind of on how the groups can interact with government, right? Because everyone's interacting with government at the local, state, and federal level. So is there best practices? Is there a committee that can look at funding with Maria and kind of have a touch base point that they're always communicating with the federal agencies, the state agencies, and providing information to the group on what's coming out. So that's just one thought that we had.
I think some of the data could influence public policy based on what we're already seeing. So it may not be a bad idea at all 3 levels of government to look at that.
Yeah, I'm happy to hear you say that. One of the things I'm most excited about with the chronic care management is the ability to collect that health score data and actually connect the changes in the health outcomes over time with the specific interventions that were applied, because that's really seriously lacking in the literature. We're hoping that that will give us some data to put behind decision making that we don't have today.
One other question, when you're talking about the CCM model, and if somebody needs transportation, maybe that can be arranged, or there's going to be a lot of, they need a phone, right? Because they can't afford a phone. Well, maybe there's a phone provided for. It's cheaper than a car or cheaper than other things. Is there any type of tools out there, or has anybody considered financial assessment? Right? If you're looking at me because I say I need a phone or I need transportation, to verify that financially that person actually qualifies, is there any network out there that can provide that type of data?
That's actually something we've been talking about for quite some time, because I think that the interesting thing and the goal here is that we align objectives, right? And the fact that the payers have the same similar type of quality metrics that they have to show improved outcomes on. They have to spend money to invest in value-based care, and guess what? There's a lot of penalties that they're paying today because they're not able to impact that. The reality is that these payers aren't going to, I think that means $55 million of penalty payments last year was made by 5 Medicaid payers because of their inability to improve these patient outcomes. They're going to continue to miss those outcomes unless they can get the providers to meet their outcomes, right? Because they're just reporting on it. So that's the value of this, and the ability to tie things together. So, we had a discussion with one of the payers where they said, listen, the challenge is we can engage that patient, but that patient doesn't have a data plan, okay? And the response was, I, as a payer, need to get that information because that's a lot easier of a problem to solve that I can't engage with the patient, right? So closing that loop, I think, is really important. If we can tie, and I know that we have some payers that have been involved with this, if we can tie the dollars that they have to spend with the penalty pay avoidance that they've been realizing, and translate that back to the providers and back to the patient, I think that's the ultimate goal. That's tying in everything, making full circle. And that's our goal. That's absolutely one of the goals with the Center of Excellence is, listen, in isolation, payers, how many penalty payments have you paid in the last 2 years? What are you doing to impact? They're all spending a lot of money, but if it's not translating into reducing those penalty payments, what are you doing, right? On this side of it, the provider, if you're not getting these incentives because of things, they need to connect the dots. It's all about connecting dots. So yes.
I don't want to get too far in the weeds, but I'll just ask a yes or no question, and we can go into it at a later date. But do you have reason to be optimistic that large healthcare systems would be willing to share personal health information to a common database like this, considering the paranoia around security?
I absolutely think so. And I think that one of the things that we're seeing is that it's now around, value-based care is a lot around population-based care, right? So, and I'll use infertility as an example, okay? Major issue, everyone wants to solve it, wants to improve it. In hindsight, they know if we can collect these data points in advance, we can do that. Realistically, today, whether it's infant mortality or whether it's patients with developmental disability or MIDD, a lot of things that we want to capture aren't being captured today. We never had knew to capture it, right? So the disconnect is that as you identify things for improving the infant mortality or the TBI patient population, the systems may not support that, okay? And the goal of, like with the payers, is we want to have a database that takes that thin slice. We don't want all the patients that are going to higher health, but the patients that have MIDD or the patients that have infant mortality, let's contribute that to a shared database. So we see a lot of that happening now. Infant mortality is a great example. Developmental disability is a great example, where across the state, they know that they have to improve it. They're not doing an effective job, and the current EHR systems don't accommodate holding that data. So it's got to be a new database that's shared. So we absolutely see it.
Good.
I've got one question in an effort to keep everybody here even longer. The demonstration center,
Yeah.
you put thought to what that's going to physically look like, given a lot of the solutions are tech-based, digital displays. You thought that through at all?
As far as where it's going to be or how it's going to be hosted?
Well, where and what it's going to look like and how.
Well, we were talking with Randy. It's either going to be here or in his basement.
Not Ecuador, yeah. Not Ecuador.
I think that from, we have groups that are providing the infrastructure to support it. Just having that physical demonstration center is going to be the next thing that we want to kind of talk about. But yeah, I think that's
We talked about initially the possibility of accommodating it somewhere in here, because this building has got a lot of capacity right now, but the extension of this is eventually there'll be a second phase of this building that'll model this one. And the idea is, as we design that, we might actually design dedicated space around that in phase 2 of the building when it comes a year or two down the road.
That makes sense. I think even some of the working group solutions may lend itself to how that demo center is structured.
Absolutely, yeah. And again, what's great is that this has been the destination for the work group meetings, right? So again, it's great that the space is available. And the plans and the vision that they have for this area and for value-based care in general is fantastic.
It's really good space, very energizing, bright.
Absolutely. Much better than your basement. So again, I want to thank everyone for attending. Look forward to your participation in any of the working groups. And if not, we'll see you here at the end of September. Thanks so much.
Are you in from Indianapolis, or is there a local office?
Local office.
Okay. The main. Okay, yes. I lived in Fort Wayne, Indiana for some time.
We did